Welcome to the EAU podcast series, Present and Future of Diagnostics in Prostate Cancer. In this sixth episode, we are joined by Associate Professor Pawel Rajwa and Professor Peter Carroll. Together, they will discuss if intermediate-risk prostate cancer diagnosed on MRI-targeted biopsy is ready for active surveillance. Join us as we embark on this informative journey.
Welcome everyone to EAU podcast, Intermediate Risk Prostate Cancer Diagnosed on MRI-targeted biopsy, ready for active surveillance. My name is Pawel Rajwa. I am a fellow at University College London, and it's a great honor for me to have today Professor Peter Carroll. Welcome, Professor.
Thank you very much for the invitation. Again, I'm Peter Carroll. I'm at the Department of Urology, University of California, San Francisco.
Thank you very much. It's really great honor for me to have you here and talk about this hot topic. So my first question is, historically, active surveillance has been reserved for low-risk prostate cancer. What factors or findings suggest it could be safely extended to selected men with intermediate-risk disease?
A couple of things. When you look at men for surveillance, you take into several factors: cancer grade, volume, PSA density, age. And this allows you to determine who's a good candidate for active surveillance. It turns out that active surveillance has been generally reserved for men with grade group 1 disease, but now we're understanding that a lot of men with grade group 2 disease may be candidates for surveillance. So we're trying to do two things. One is to extend indications for surveillance, and two, make surveillance less burdensome. So can we identify patients who are at low risk of progression, who don't need frequent biopsies or MR imaging? And we're accomplishing both.
Thank you very much. And in your opinion, how has MRI and MRI-targeted biopsy changed our understanding of intermediate risk prostate cancer? And how does it influence risk stratification compared to classic systematic biopsy and digital Lexar examination? How MRI changed our understanding?
MRI has changed dramatically how we diagnose and treat men with prostate cancer. One, we've identified that many men with elevated PSA don't have cancer. So you want to, before going to a biopsy, you want to repeat the PSA, and then you want to do a test of specificity to determine who with an elevated PSA needs a biopsy. Many ways to do that: PSA isoforms, exome DX, 4K, or MRI, which is frequently done in Europe and becoming more popular here in the US. So what MRI does is two things: determine who needs a biopsy and allows you to do a better biopsy. Now, historically, we've identified that about 15% of men have a higher grade lesion outside the target. So again, that's generally at the first biopsy, you do systematic and targeting, and that's the most common form of MR-targeted biopsies currently. But work done at UCSF and elsewhere suggests that the target is the place of the dominant tumor 80+% of the time. And if you miss the higher grade lesion, it's usually because you missed it at the periphery of the target. So recent work suggests that maybe you do a targeted biopsy, but just do a better biopsy, sample the target a little bit better. And we've identified that you can still miss cancers outside the target a small number of times, but generally these are low volume, favorable histologic subtype grade group 2 tumors.
Thank you very much. And what does current evidence tell us about the safety and long-term outcomes of active surveillance in men with intermediate risk disease?
Well, a couple of things. When urologists talk about intermediate risk disease, they generally define it by grade alone. I think urologists have been held hostage by Gleason score. So we think of insignificant tumors being grade group 1, and then it's like crossing or going over a cliff. If you have grade group 2 disease, automatically have clinically significant disease. But we're identifying now that low volume secondary pattern 4, these patients are generally thought to be lower risk. So again, the way you identify these is you look at confirm the grade group 2 is real. We've seen a lot of men overdiagnosed because of so-called tangential sectioning. That means when they look at the biopsy, they misread grade because of the way the samples are cut. But a low volume grade group 2 disease is really generally a favorable risk tumor. So what you do here, we generally use a CAPRA score, a multivariable risk model, which takes into not only just grade, but volume, PSA, and other things. So I would use a multivariable model, look at the grade group. The other important thing nowadays is we realize that pattern 4 is not just one disease. So this histologic subtyping. So again, you can go ahead and confirm the grade group 2 disease, But importantly nowadays, we ask pathologists to look at the histologic subtype. So by that I mean intraductal large cribriform cancers tend to be the higher risk cancers. But for the borderline histology or the favorable histology, these are generally favorable factors. So again, the low volume, secondary pattern 4, favorable histologic subtype, favorable PSA density, favorable MRI. I think these patients can be followed. Now, they are more likely to require treatment compared to grade group 1 disease. So it is true, grade group 2 disease needs to be followed a little bit more carefully. They have a higher risk of upgrading by volume or grade, but it appears to be safe. But what you can counsel those patients is that they're more likely to require treatment compared to grade group 1 disease.
Thank you very much. And how about those patients diagnosed with MRI-targeted biopsy? What do you think about this, stage or grade migration? Does it impact the outcomes that we are currently diagnosing these men with MRI-targeted biopsies?
The answer is yes and no. I think the key, what people have to understand is that if you have historical definitions of risk based on volume, number of course positive, if you oversample the target, you can overestimate risk. So again, if you take 6 or 8 biopsies from the target, and historically your operational definition of high volume was 50%, you in fact can overestimate risk. The other thing to be a little careful about is grade group 3 disease. So we find now with oversampling, you might have Gleason 3-3, 3-4, small volume 4-3 based on a small biopsy. So again, when you oversample, just be clear that you're going to take more biopsies, and if you only do targeting, you will lead to a higher estimate of volume because you're sampling the target over and over. So I think it's volume estimates based on targeting where you could overestimate risk. So I would be cautious in that regard.
How do you see the role of molecular markers evolving in determining candidates for active surveillance in intermediate risk prostate cancer? What do you think about this area of clinical practice and research?
So in clinical practice, genomic markers are not used commonly. Now, we at UCSF have done it for many years. And it is true that genomic profiling does predict outcomes. So if you look at men with higher genomic scores, whether you use Prolaris, Decipher, or Oncotype, higher genomic score tends to predict for a higher risk of progression. Doesn't mean it'll be high risk progression, but progression. Now, what interests us nowadays is it turns out that histologic subtyping and genomic scoring actually correlate over 80% of the time. So it may be that if you just actually look at histologic subtype, you may not need genomic profiling. The other area that interests us and early results suggest that it's going to be predictive is the use of AI. Our recent research is submitted to ASCO suggests that looking at an artificial intelligence network algorithm may predict who is more likely to progress on surveillance. We have shown that AI algorithms assessing men who've undergone surgery can predict the outcome versus biochemical recurrence, metastases, and overall survival. So that's new data. And now we're in the middle of assessing an active surveillance cohort using artificial intelligence to see whether it predicts. My sense is it will predict. Around the world, you make a cancer diagnosis based on a biopsy. So I think if you have access to artificial intelligence and we can validate this may be, again, it's a non-destructive form of assessment. So you're not having to extract RNA or DNA. No tissues being lost, and it may be an easier and less expensive way to assess risk compared to molecular markers. Now we'll have to see how these are priced, but I think this is an area both in imaging and in pathology where I think artificial intelligence is going to have a great impact.
Thank you very much. I also believe that it's very, I would say, promising area of research and clinical practice. And I also agree with pathology and MRI. Let's see maybe which will be more predictive in the future. Probably it will be also a combination of both. And regarding molecular markers, what do you think about BRCA mutations? And would you recommend active surveillance in patients with BRCA2 mutations or rather not? Low risk and intermediate.
So this is a matter of much controversy. Now, one, I would never do a prophylactic prostatectomy in someone who's carrying a mutation. Not everyone who carries a mutation is going to develop prostate cancer. And the other thing is we have much better means to assess the prostate nowadays, MRI, targeted biopsy, molecular markers than we had before. So what I tell men is that if you have a mutation, you're at a higher risk. If you have a mutation, if you develop cancers, they may be more significant, but it doesn't mean you have to be treated. So what I tell them is I advise them of the risk, but I see a lot of young men who have these mutations who haven't completed their families or other things. And I think for them, a period of surveillance is quite reasonable. Now, it's got to be careful surveillance, got to have periodic MRIs and biopsies. But personally, I think a well-informed patient can make a decision on their own about this. But I do have men who carry mutations on surveillance. It's a quality of life issue for them, but they need to be followed more carefully.
Also, I think the other issue is that they are at higher risk of other malignancies. So
Right.
yeah, that's like general, I would say, cancer screening. And okay, so what is your approach in your clinics when considering patients, about active surveillance for intermediate risk prostate cancer? Is there any specific protocol you use, or when do you initiate treatment? How do you manage patients with intermediate risk disease?
So I think how we manage surveillance is changing over time because we're trying to develop algorithms which determine who needs careful follow-up and who may not. So we're actually working at this because, you might tell one patient you don't need another MRI for 4 years and another patient you need an MRI in a year. Now, generally for grade group 2 lesions or for the small number with grade group 3, we recommend a repeat MRI and biopsy at usually 1 year's time. Now, we always want to be sure that, in fact, they've had a baseline MRI done. I still see patients who have not had a baseline MRI. So if I see a patient grade group 2 confirmed, haven't had an MRI, I get the MRI to be sure the tumor has not been undersampled. But generally, we follow these patients more carefully because their likelihood of upgrading or progression by volume or grade is higher. So we generally, not always, but generally will do a MRI at 12 to 18 months with a repeat biopsy. Grade group 1, low volume, I think those patients don't need an early confirmatory biopsy. But grade group 2, we usually do an early confirmatory biopsy, and that generally depends on what the patient desires. Do they want it at 6 months or they want it at 18 months?
There is any specific clinical pathologic criteria that triggers treatment in your practice?
Prostate cancer, again, it's shared decision making. We tell patients these are your risks, and I've had patients who have had clinically significant disease decline treatment, and we follow them very carefully. So I tell patients we make decisions based on 3 criteria. One is a cancer grade, volume, extent, MRI, genomics, histologic subtyping, aging health of the patient, number 2, and lastly, their own personal preferences. And we have to respect that, their own personal preferences. I have a lot of patients who say, well, look, my life is good. I'm willing to take some risk to try and avoid treatment, and I respect that. But generally, higher volume, grade group 3 or higher, we would generally treat those patients because we don't have good information about surveillance on grade group 3, higher volume disease. Grade group 1 and 2, we have pretty good evidence to suggest that's safe. But if you progress clinically significantly, I tell patients, well, look, we don't have as much information about men like you anywhere in the world as we do men with lower grade disease. So we'll start this issue of treatment. Now, it doesn't mean we'll remove their prostate, but it could be they get radiation, focal therapy, or combinations. The one thing that we have not been able to do, I know where you're at, you clinically do biopsies based on a change in MRI. Because it's often said that if there's no change in MRI, you don't have clinically significant disease. Now, our results at UCSF don't uniformly support that. We're looking at this, but we have a data set of about 3,000 men on surveillance. And I've looked at this issue of a change in MRI as the only indication for a biopsy. So it's for cause. But our results suggest that, in fact, you may miss significant upgrading if you rely on that alone. Now, we're exploring our data set more carefully about this. So right now, we will do routine rather than for cause only. Now, if there's a change in MRI, you go from a grade group 3, a PI-RADS 3 to a 5, well, we'll biopsy the patient. Let's say you have a patient who's had a PI-RADS 4 or 5, well biopsied, MR-targeted. Do we wait for a change in volume or a change in PI-RADS? Not always. So I think this is one area where we're looking more carefully. For-cause biopsies alone may not identify clinically significant disease, whether it's on surveillance or after focal therapy.
Yeah, and I think really artificial intelligence will help us. And another question, how do you de-escalate active surveillance in men? The man reaches 80 that you tell the man who has intermediate risk prostate cancer that at this time point we are not longer following you, or how do you manage this?
So I discuss it with the patient. So I can tell you that surveillance protocols at UCSF have de-escalated. So initially, when we started this, like many others who started this, we were risk adverse. But now we know that you can predict progression based on all these things, PSA density, MRI, genomics, volume, histologic subtype. So a low risk patient can be followed. Now, what we would like to know, and we don't know yet, can you identify a patient with low risk disease, which you say is you're done. Your risk of progression is so low, you don't need another PSA. We're not there yet, but hopefully we're getting close to it. We do see a small number of men who progress significantly later on. So remember, on progression, it could be an issue of sampling. You didn't sample the target well enough, or this issue of biologic progression, where the tumor changes its behavior. Now, biologic progression is rare, but we've seen it. We've seen some men who go patterns low risk, and boom, in the out years, they develop a biologic progression. Low likelihood. So most progression is actually little progression. So if you look at men with grade group 1 disease, when you progress, it's usually go to grade group 1 to grade group 2. At 10 years, the risk of clinically significant, what I call major progression, is only about 17% for grade group 1. It's higher for grade group 2. Most of the progression we see is a change in volume or a grade group, but not a big change, not a big change in volume or a big change in grade group. It's moderate. So most progression is moderate. A small number is significant.
And do you believe that active surveillance will become standard of care for intermediate risk prostate cancer and replace intermediate treatment in some of the men?
The indications for treatment are variable around the world. And this is remarkable to me that even in the United States, we see significant geographic variations where we see high use of surveillance for low risk disease in some areas like San Francisco. And yet you can go to another part of the country and you can see that, in fact, surveillance is not uniformly utilized. And I think around the world, you'll see this based on practice patterns, technology, populations' thoughts about cancer in general. I mean, so for some men, a cancer diagnosis period, they can't accept the idea of surveillance. Now, surveillance will increase. It'll increase for grade group 1 and smaller grade group 2 disease. Now, will it be replaced by focal therapy? And we're seeing a lot of men with grade group 2 disease being treated with focal therapy. This issue of risk reduction. Instead of surveillance, you'll maybe try and reduce risk by doing focal therapy. It's a concept we're looking at, and I think those doing it need to report results very well strategically and in great detail. I don't think it'll ever be utilized uniformly, but it'll become much more common, certainly for favorable intermediate risk disease. But if you have a higher volume grade group 2 disease, abnormal histologic subtype, I think those patients should be treated. So surveillance will never be the standard option for all men with intermediate risk disease. I think we'll see that with time, more and more men with intermediate risk disease, we call favorable risk disease, will be candidates for surveillance.
Thank you very much. And at the end, I would like to ask, what research directions do you think are critical, to expand active surveillance in the future? What are what it would be advice for young researchers, what they should actually study to allow more men to be included in active surveillance protocol, more men with intermediate risk disease?
So what I would tell young investigators, clinicians to do is, one, build infrastructure, because you never know how technology will change. So that means if you treat patients, document their outcomes very carefully. With surveillance, surgery, radiation, document your outcomes. So understand this over time. It always amazes me, a lot of major centers are not documenting their outcomes. Two, be open to new technology. You never know what new technology will come along, but be ready to test it. So you see, I started early on documenting outcomes in all my patients, having them sign consent for research. So because I knew with time that there'd be new technology that you didn't want to test prospectively. You wanted to be ready to test it now. And that's what we've been able to do with AI, genomics. So we've had these patients, they sign consent, we have their tissue, we know their outcomes, we know how many recurred, how many progressed. And now we have new technology, we can test it now. Prospective study takes 5 or 10 years. We have those outcomes and we can identify technology which could be put into practice, I think, earlier. So build infrastructure, be open-minded, be ready to test new technology and test it well.
Thank you very much again, Professor, for your insightful interview. It was a great pleasure and great honor for me to talk to you. Thank you very much.
Thank you for the invitation. It's been my pleasure.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.